So please pull the plug on epirubicin. I've been making this argument for over a decade already. So in the bad old days, when I practiced 25 years ago, we used to give high-dose infusion of 5-FU and cisplatin. So this was a 4 to 5 day infusion of 5-FU with 75 to 100 milligram per meter squared of cisplatin. This was a killer regimen. Usually about 20 or 30% of patients would wind up in the hospital from some side effect. It had a very low response rate and a poor survival. But this was the standard arm of many clinical trials for many years, and like the Mayo Clinic regimen in colon cancer, this regimen makes anything else looks better. So what happened in Europe in the 1990s, the EORTC compared platinum 5-FU to other regimens, FAM-TX and ELF. These were active regimens at the time, 245 patients. They were all terrible. Response rates of 10 to 20%, survivals of 7 to 8 months. So actually the Europeans were way ahead of us on this. They said, let's get rid of all of these horrible regimens and let's do something else. So they got rid of 5-FU platinum. Now the British compared FAM-TX to ECF. ECF was a protracted infusion of 5-FU and a lower dose of cisplatin, and this was a positive study. Protracted infusion 5-FU was better than bolus 5-FU, and they saw response and survival benefits, so ECF became the cornerstone of chemotherapy in Britain, but in continental Europe they said no more 5-FU cisplatin, we've got to look at something else. So the British continue to pursue this regimen, ECF. Other European investigators abandoned high-dose 5-FU cisplatin, and they actually said, boy, you know, they're developing these regimens in colon cancer that are really well tolerated, like Fallfox and Folfiri, and why don't we explore this schedule of chemotherapy? So this was being done in continental Europe, and they were also looking at 5-FU regimens in combination with irinotecan and taxanes. So what's the bottom line on ECF? Yes, in their early studies, it did have a better response rate, about 40%, and a median survival of about 9 months. To me, what I learned from ECF is you don't need to give 100 per meter of cisplatin. You can give 60 per meter of cisplatin and get a fair outcome. And also, as we learned from colon cancer, infusional 5-FU is better than bolus 5-FU in metastatic disease. But I learned about this from the MRC when I was reviewing their REAL-3 protocol for the UK. They sent me the REAL-3 protocol, so I really could see how do they set these protocols up. So it turns out in the Medical Research Council that they only do CAT scans at 3 months and 6 months. So why is the PFS always 6 months? Because that's when the second CAT scan is done. So they only do CAT scans at 3 months and 6 months. So as a consequence of that, response rates are never confirmed on any of these British studies. So, and the PFS is always 6 months, which is the time of the second CAT scan. Every time I've seen ECF put in a study that's more rigorous, the PFS drops to 4 to 5 months, and the response rate drops to about 35%. So to say that ECF is somehow so much better than anything else, if you don't look, you don't know. So what about epirubicin? Well, the British always quote this meta-analysis. Here's the forest plot on top, and this is looking at anthracycline-containing chemotherapy. And the biggest contribution, so you can see that the bar is a little bit to the left, favoring the addition of anthracycline. However, this is a very flawed meta-analysis, because the biggest group of patients in this meta-analysis comes from the MRC. But the MRC study was not a comparison of ECF versus CF. It was a comparison of ECF versus MCF. So it was looking at two triplets. And MCF was mitomycin. So this was not saying that epirubicin is better, but that epirubicin was better than mito. But that doesn't mean that epirubicin is better than nothing. So, and actually on this ECF-MCF trial, the MCF arm was worse. It was inferior, and it was more toxic. So this meta-analysis, they always quote saying that you have to give an anthracycline, does not ask the question about whether or not an anthracycline benefits. So to me, this paper should have had an editorial in the JCO. This kind of slipped under everybody's radar. This was a head-to-head comparison in France of FOLFIRI versus ECX. Does epirubicin add any benefit? And again, CAT scans were done every 2 months. So they didn't do CAT scans at 3 months and 6 months. If you were really going to say a response rate, it had to be confirmed. So this was 416 patients, a third GE junction and 2/3 gastric. And if you look at the curve on the left, the primary endpoint of this trial was time to treatment failure. So time to treatment failure not only encompasses progression, but it also encompasses toxicity. And ECX was worse. So the yellow line is ECX. So it actually was worse than FOLFIRI. And if you look at all the other endpoints, and again, these are now real response rates, 39%, no difference in response rates, no difference in progression-free survival, and no difference in overall survival. And actually, time to treatment failure favored a doublet, FOLFIRI over ECX. So more recent iterations of ECF have looked at substituting oxaliplatin and capecitabine, and really no differences in response rate for these different regimens. But again, remember, CAT scans at 3 months and 6 months, so these are probably inflated response rates. And again, boy, that PFS, it's 6 months. Where did that come from? So the PFS is 6 months in every arm, although EOX nudged out a little bit higher at 7 months. And then a lot of my colleagues made a big fuss about this. So the survival in 3 of the arms was 10 months, and EOX was 11 months. So EOX, now that's ordained, that's the best thing we've got to treat patients. 1 month difference in survival. So, but is it really the epirubicin that does this, or perhaps better tolerated capecitabine oxaliplatin? So here's Kang's study of capecitabine versus 5-FU, and if you look at the survival here, it's almost 11 months for capecitabine platinum. It actually was better than 5-FU platinum. So capecitabine platinum, no epirubicin, you got 10.5 months. And here's a German study of, this is colon cancer-like chemo, so infusional 5-FU oxali versus infusional 5-FU cis, 10.7 months. So do you really need the epirubicin thrown in there to get 11 months? So now we have CLGBE ECOG. This is about to come out in the JCO in the next few months. So here's an American head-to-head comparison of different chemotherapy backbones, looking at, this added cetuximab, so probably, in retrospect, not a great drug, but a comparison of ECF, irinotecan platinum, and Fallfox. And if you look at the response rates, no difference between ECF and Fallfox, about 55%. No difference in survival. Actually, Fallfox was a little better at 12.4 months compared to 11.5 months for ECF. Progression-free survival favored Fallfox, and time to treatment failure favored Fallfox. So I know it's a randomized phase 2 trial, but to me, I can't justify giving a patient epirubicin based on these data either. So here we look at all the pooled phase 3 trial analyses. These are the industry standards, DCF and ECF, 35 to 45% response rates, and I think, as I said, probably the response rate for ECF is inflated. Here are all the doublet regimens, and these are probably better conducted studies where patients got CAT scans every 2 months. No difference in time to progression and no difference in survival. Okay, so how does ECF fare when you pair it up with a targeted therapy? So, the British love this cocktail so much that let's throw in a targeted agent. So REAL 3, this is EOX with or without panitumumab. Oh my goodness. The people that got panitumumab did dramatically worse. So not a good partner for a targeted agent. The overall survival was actually dramatically inferior for EOX plus panitumumab. And I found it interesting when the investigator presented these data at ASCO and said, well, we were having an investigator meeting in Brighton, and we decided to look at the data. I'm not sure even if they had any interim analyses built in. And they were so shocked about how horrible this was that they immediately closed the study. And PFS was also worse. So you would think that seeing this really terrible negative result for panitumumab plus EOX, that both the British and pharma would learn their lesson. No, let's drink the Kool-Aid again. So let's combine EOX with riletumumab. It worked so well with panitumumab. So this was the RILAMET study. This was IHC-enriched MET-positive patients, EOX, or here it's ECX, with or without riletumumab. So you can probably predict. It wasn't quite as dramatically horrible as panitumumab, but you still had inferior survival with ECX plus riletumumab, as well as worse progression-free survival and a worse response rate. So, my dear colleagues, I'm speaking from the pulpit here. Pull the plug on epirubicin. Standard chemotherapy combines a fluorinated pyrimidine and a platinum agent. Colon cancer schedules are better, and oxaliplatin is favored. EOX, you get the same survival with CAPE, CIS, or 5-FU oxaliplatin. Epirubicin added to 2-drug chemotherapy failed to improve outcome in 2 recent studies, including FOLFIRI besting ECX and Fallfox either better or equivalent to ECF. And not only that, this is a horrible regimen to combine with targeted agents. Spare your patients, drop the epi.